Sorry. It's my great pleasure to introduce Dr. Joseph DeBiase. And I have to say, he was quite brave in being the first Grand Rounds speaker this year, so be nice to him. Dr. DeBiase is a faculty member in the Division of Infectious Diseases. He completed his fellowship in infectious diseases at The Ohio State University in Columbus, Ohio, where he also served as clinical instructor. Dr. DeBiase trained at St. Vincent Mercy Medical Center in Toledo, Ohio, where he also served as chief resident. And I just want to observe that there is a disproportionate number of chief residents in the infectious disease world. Dr. DeBiase earned his MD from St. George's University, and he also has a Master of Biomedical Sciences from Barry University in Florida, and a BS in Neuroscience from the College of William and Mary. As an assistant professor in the Infectious Disease Division, he contributes a great deal in terms of training our fellows, medical students, and residents, and he demonstrates exceptional dedication to his patients. I have never met anyone more detail-oriented than Dr. DeBiase, and he has a variety of interests, including endocarditis, which you'll hear about today, prosthetic joint infection, and especially mycobacterial infection. So, Dr. DeBiase. Oh, okay.
Everybody hear me? Oh, perfect. So you heard Dr. Hanrahan, you have to be nice to me since I'm leading this off. And I told Dr. Kayam that you should have found a better speaker for leading or kicking off the 2024 Grand Rounds. So what I wanted to do was do a lecture or kind of a bunch of case scenarios and decisions and dilemmas regarding endocarditis that we all encounter on the floors and in the hospital here. So I have in this lecture about, I think it's 5 kind of clinical scenarios or dilemmas. We might skip number 3 in the interest of time. We'll just see how we do. So I have no financial disclosures. The only disclosure that I do have is I do show my dogs in every presentation since residency. So there is my Messi and my Baron. And on the right is their birthday, and yes, they eat better than I do. So clinical scenario 1 is just kind of, there's no real stem for this question, but clinical scenario 1 is just regarding imaging and endocarditis. So I wanted to look into the literature when you talk about what should we be ordering when you suspect endocarditis. And the 3 in particular that I wanted to look at, I know the Duke's criteria has updated and has more imaging, but the 3 that I wanted to look at was the transthoracic echocardiogram, the transesophageal versus the cardiac CT. So just to briefly start off, the incidence of endocarditis is roughly 2.6 to 7 cases per 100,000. However, this ranges wildly when you talk about the different species or the pathogens that you find in the patient's blood. So the bacteremia, the pathogen, really kind of dictates whether it's a high risk or a low risk for having endocarditis. So for instance, Staph aureus bacteremia, especially when they're coming from the community, it can carry a risk of endocarditis when they have a bacteremia all the way up to above 30%. When you talk about Enterococcus faecalis, again, depending on a couple of clinical factors, which we'll get into later, but the incidence of endocarditis can be as high as 26%. And that's specifically with Enterococcus faecalis. For some reason or not, the other species of Enterococcus don't carry this risk factor, which again, we'll talk about later, like Faecium or Raffinosis or the other ones. But faecalis in particular can be quite a risk for endocarditis. And then we have the strep species. And I fully admit that I still struggle with this every day on the floors because before this chart right here is essentially basically a chart from, I believe, the AHA, where they're looking at just classifying when you have a streptococcal bacteremia, okay, is this low, moderate, or high risk for developing or having infective endocarditis? And besides giving it that classification as low, moderate, or high, it really doesn't give much else explanation, just that these pathogens might be a little bit more than others to lead to endocarditis. So to start off with the imaging, I looked at this one trial, which was a meta-analysis of many trials combined. And so this was basically people, the inclusion criteria was people suspected of having infective endocarditis due to any cause. It was a systemic review and meta-analysis of observational studies. And essentially what they were doing was trying to compare the transthoracic versus the gold standard. So everything was compared against the transesophageal echocardiogram. So in total, with all these 16 studies, there was almost about 3,000 patients, of upwards of almost 800, or 28% of them had vegetations on the transesophageal echocardiogram, which was the gold standard. So essentially what they found in this, and you don't have to read through all of these tables that I have throughout this lecture, I'll try to point out what the major highlights are, is that when you talk about the fundamental or harmonic transthoracic echocardiogram, most of the time our echocardiograms are harmonic now. It just has to do with the difference of the sonographic waves. So most of them, everything nowadays is harmonic transthoracic echocardiogram, but we see that the sensitivities are not. The sensitivities range from about 41 to 61% sensitivity when you compare it to the transesophageal echocardiogram. When you talk about harmonic transthoracic echocardiogram, the sensitivity was 66%. When they teased out just the harmonics transthoracic on native valves, the sensitivity was 66, so still not the best. However, it did improve when you had a harmonic transthoracic echocardiogram with conclusively negative results, aka when the technician or the cardiologist was reading that they had good windows, they definitively didn't see vegetations, it was a good reading, as opposed to a lot of the times when we get back echocardiogram reports and it shows, well, you know, either poor windows or indeterminate results. But we see when we have those conclusively negative readings that the sensitivity did in fact end up going up to 90% with a decent negative likelihood ratio. So how about when we talk about detection of abscesses? So that would be this chart on the left here, and I'll just kind of tease out for you. So when we talk about the transthoracic echocardiogram, when we're trying to detect cardiac abscesses or perivalvular abscesses, it was very, very, very poor. So the sensitivity ranged from 0 to 66%, in 29 to 100% for fundamental and harmonic TTEs respectively. So very poor. The transthoracic echocardiogram was very, very poor in detecting perivalvular abscesses. Then when we look at prosthetic valves, so why does infectious diseases always recommend that we get a TE with, especially when a person has a cardiac device or prosthetic valve? It's because the sensitivities are very poor, again, when you're talking about transthoracic echocardiograms and with respect to prosthetic valves. So we see that the sensitivities overall are quite poor, you know, less than 50% when they are combining most of these studies in this meta-analysis. So in terms of, I think, the first line, you know, a transthoracic echocardiogram is good. However, we just have to understand that its limitations, especially when you're looking at prosthetic or cardiac implant devices, abscesses, perivalvular complications, or just that indeterminate results. Next. So then we talk about, or then moving forward, because the Dukes criteria in 2023 was updated to have some more imaging incorporated into it. And one of those imagings were the cardiac computed tomography, or the cardiac CT. So two studies that I want to point out that I found, Safoy et al., one of their findings was that the ability of the TEE, and so this is cardiac CT versus the gold standard TEE. So Safoy et al. Found the ability of the TEE to detect vegetations was significantly better than the cardiac CT. The CTA, or cardiac CT, exhibited higher sensitivity than the TEE for pseudo-aneurysm detection, but with similar diagnostic accuracy. So the takeaway highlights from this study was that the TEE performed better than the cardiac CT for detection of valvular infective endocarditis related lesions, while the TEE and CT were similar in detection of perivalvular complications. And the CT, cardiac CT, may be useful when the TEE is equivocal or not feasible for left-sided infective endocarditis. And Jane et al., another study that was a systemic review and meta-analysis, they looked at, again, cardiac CT versus the transesophageal echocardiogram. And essentially, when you looked at the first point here, detecting vegetations, right here, we see that the sensitivity was a little bit better when you talk about the TEE, say 96 to 85, versus the cardiac CT. In detecting vegetations in a prosthetic valve, we see that the sensitivity for the TEE was still a little bit better than the cardiac CT. However, the specificity was a lot better with the cardiac CT when you talk about prosthetic valves, so 74 to 94%. And then when you talk about perivalvular complications, when you're comparing the TEE versus the CT, we see that actually the CT, or the cardiac CT, actually did better when you were talking about perivalvular complications. And so their takeaway points or highlights.
I know.
Yes.
Zoom 1959.
I'd rather,
I know, but I want to put it in mine.
yeah, put it near us as well. That's your EVMS sign in, I guess.
Oh, no, it's my Zoom
Zoom
sign.
sign, yeah, your Zoom sign in. Zoom sign over.
Okay.
1951.
Everybody hear me? Okay. All right. Sorry about that.
You want.
So the highlights, where was I? Yes, Jane et al. The highlights were that the TEE and the cardiac CT both demonstrated good diagnostic accuracy for detecting valvular involvement and complications of infective endocarditis. The TEE performed better when you were talking about detecting leaflet defects, whereas the cardiac CT did better when you were talking about perivalvular complications. So overall, these are my kind of takeaway points when you talk about all of those images or all of those imaging techniques. One is that the transthoracic and the transesophageal are obviously key imaging techniques when used to diagnose infective endocarditis. However, the TTE had a good sensitivity and negative likelihood ratio only in the setting of a conclusively negative result. The TEE is recommended in the setting of inconclusive TTE or a high suspicion of infective endocarditis. The TEE did perform better when you were talking about smaller vegetations. It still could detect perivalvular complications. It did well in prosthetic valves and in implantable cardiac devices comparatively to the transthoracic. And when you talk about the cardiac CT, it did a decent job of detecting vegetations in particular. Where its sensitivity went down was when these vegetations were smaller vegetations. But it did do really well, and sometimes even better in some studies, when you were talking about perivalvular complications, such as abscesses, pseudoaneurysms, and fistula formation. And I didn't want to go in-depth detail, but these are also on the Duke's criteria, and the TAG WBCN is in the European Duke's criteria. But just to round out the other diagnostics that have now entered the Duke's criteria, the PET scan is good for detecting inflammation and infection. Its data is a little bit better when you talk about prosthetic valves infections and when you talk about cardiac implant devices and VAD infections. And the diagnostic accuracy, though, is really dependent on timing of when you're ordering the PET scan, because it's detecting inflammation and infection. And so when you're obtaining it, especially within 3 months of a post-surgical procedure, it's not that its sensitivity drops off, because it might just be detecting inflammation from the recent surgery. And the TAG WBC scan is not in the US 2023 guidelines, but it is in the European Duke's criteria. And this is used early in the post-operative infection period. So unlike the PET scan, it does have a little bit better sensitivity in that early post-procedure window, because it's not reacting towards the inflammation and infection. It might just be a marker of infection. So its literature is a little bit better when you talk about prosthetic cardiac devices, VAD infections, or graft infections. Although its sensitivity, when you talk about the TAG WBC scan, its sensitivity does lower when you have either A, small vegetations, or B, kind of chronic infective endocarditis, where you're not having that like pyogenic endocarditis, so non-pyogenic endocarditis, such as like Coxiella, T. Whipple, or some of the other infections that can cause chronic endocarditis. Again, these two tests, I wanted to include them. However, these are not obviously first line. These are where you're going to if you're struggling, you have equivocal results on your other test, or maybe you can't obtain your other test because of some other reason. So these are now entering, the guidelines. So that was imaging. So for the rest of I think the case, like kind of the clinical scenarios, I wanted to basically just give some very common scenarios that we find in the hospital, nothing complicated, but just kind of dive into the literature with these. So clinical scenario 2, if anyone wants to answer, please. We have a 53-year-old male with a past medical history of infective endocarditis who presents to the hospital with fevers, chills, times 7 days, and he is diagnosed with Enterococcus faecalis bacteremia in 2 sets of blood cultures. And when you question them, there's no real etiology for it. You can't really find something that's glaring, like a urinary tract infection. So should I be concerned about infective endocarditis, or do I need an echocardiogram? So the answer is yes, no, possibly. It depends on other factors, or I've already consulted infectious diseases, let them worry about it. Anyone want to answer? A and T, okay. So most people want an echocardiogram and have consulted us. Awesome. So I just wanted to point out, this is the updated Duke's criteria, but I just wanted to isolate out one thing, and that's basically a part of the one of the major criteria under the microorganisms section is that they did update the typical bacteria that are considered a part of the major criteria. And so one of those updates was E. faecalis that came about that is now considered a typical bacteria for the major criteria. But Enterococcus, the reason I added this is Enterococcus is very difficult. I find it a very difficult organism to deal with, mainly because it's not as virulent as some of your other pathogens. And so it's not that pathogen which is going to bring a person rushing into the hospital like, say, Staph aureus would. This is kind of a pathogen that can give somebody subclinical symptoms for a very long period of time. And I've seen even patients where they might have symptoms for a month or two. By the time they get to the hospital, not only do they have endocarditis, they might have brain lesions and et cetera, but it wasn't drastically bringing them to the hospital. So this is kind of why I find Enterococcus in particular sometimes very difficult to deal with. But persistent, technically defined by greater than 72 hours of antimicrobial therapy or persistent bacteremia, has demonstrated a higher mortality for patients when they have that, blood cultures positive greater than 72 hours with treatment. And the rates of infective endocarditis in the setting of E. faecalis bacteremia can be, like I said on one of the first slides, as high as 26%. But there's so many factors that go into your risk for having infective endocarditis when you talk about E. faecalis. And just to point out some of these, one in particular, which I hinted at, is that the species is faecalis and not faecium or raphinosis or some of the other ones. For whatever reason in the literature, faecalis is one of the really higher risks of infective endocarditis comparatively to the other species of Enterococcus faecalis. Some of these other ones are kind of quite self-explanatory and in our Duke's criteria, like prosthetic valve, history of prosthetic valvular disease, embolization, et cetera. Some of the other ones I found, unknown source, which we'll see plays into a factor, high number of blood cultures, and a monomicrobial bacteremia, which we'll see comes into play with risk factors with some of these scores. So I'm sure you've heard about two scores when it refers to Enterococcus bacteremias. Again, we're going to just go over them and look at the literature behind them, and so you feel a little bit comfortable about these. So how it started off was, first of all, the NOVA score. When you talk about, and this is just Enterococcus faecalis, not the other species, but the first score was the NOVA score. And NOVA stood for N, number of positive blood cultures greater than or equal to 3, got 5 points. You had origin of infection that was unknown, that gave you 4 points. Valve disease gave you 2 points. Auscultation of murmur gave you 1 point. And this was later validated to have a pretty decent sensitivity and specificity of 97 and 23%. And again, when I talk about this, I know the specificity for all these scores going forward isn't that great, but what I'm looking for in these scores is essentially, can I trust it when I do not have, when it doesn't meet the criteria for scoring? So can I trust this? Is there a low false, or a good, can I trust a negative result essentially? So that sensitivity is what I'm looking for. So this got, you can calculate out the NOVA score, but it got a little bit confusing because everything has different points. It's kind of easy, but still everything has different point system. And so Burge et al. Tried to simplify this. And ultimately what they did was try to aim and improve the NOVA score. And so this was a retrospective study in a population-based cohort of patients. And again, this was only looking at monomicrobial E. faecalis bacteremia. And so when they were trying to improve the NOVA score, they tried to add a couple more variables to improve the score and simplify it. So what they found was that there was a couple of things that kind of stuck out in the DNOVA score, which they later used in the score. And one is duration of symptoms greater than or equal to 7 days. So you're clinically asking the patient, a good history about when any type of symptoms might have started, fevers, chills, night sweats, when they started to feel ill. So if you were greater than or equal to 7 days, you got a point. Embolization got a point. Number of positive blood cultures, 2 or greater, got 1 point. Origin of infection unknown, got a point. Valvular disease, defined as native valve disease, previous infective endocarditis, or presence of prosthesis, got a point. And so did auscultation and murmur. So this you didn't have the 5, 4, 3, 2, 1, or whatever. Everything was 1 point. You would add it up. And when they looked at this new de novo score, it found that the sensitivities were 100%, specificity of 62%. And the number needed to screen to find 1 case of infective endocarditis was 1 for every 2.4. And this was looking at the de novo score of 3 or greater. So 3 or greater was considered high risk when you were looking at the score, and that you should be concerned, or at least get some imaging and be concerned for higher risk of having infective endocarditis. So going back to our clinical case 2, I could see a de novo score of 4 on this patient. So you guys were absolutely correct. I have a past medical history. So I have fevers and chills. I have 2 sets of blood cultures, which meets the criteria.
And your insurance covers all those inhalers, right? You have no problem. You've been taking them.
Thank you so much. So I would absolutely get an echocardiogram on this patient. I do have a de novo score of greater than equal to 3 or greater. I will say that we are going to talk about this score and 1 more score. These should not replace your clinical judgment. These are just another tool in your arsenal that you can use when you're reviewing your patient's case and trying to determine your risk factor. They should not replace your clinical judgment. So actually, like I said, in the interest of time, I'm going to skip, and if we have time, I'll come back to clinical case 3. That's just a little bit more in-depthy ID stuff. So I wanted to get to the other 2 cases before we would go back. Clinical case 4. So this is another one that I wanted to dig into the literature for. Because I hate strep bacteremia and whether I need an echocardiogram or I don't. And as you can see, when I think it was the second slide that I showed, was that before, when I showed that AHA article, they were just kind of classifying the different species of strep and into low, moderate, or high risk of having endocarditis. And well, what do you do with it when it says, oh, this is a pathogen that might have moderate risk of having infective endocarditis when they have bacteremia? So I kind of wanted to see if there was something more, something better, some better tool that we could use. So clinical scenario 4, if anybody would love to speak up as well. We have a 42-year-old female who presents from the community with the chief complaint of fevers and night sweats times 7 days. Blood cultures demonstrate Streptococcus sanguinis and 2 sets of blood cultures. Would you perform a transthoracic echocardiogram? Yes, no, unsure, depends on further investigation. C. Okay, well, let's look to see. Thank you for answering. Let's look to see what we would do. So actually, these 2 articles that I'm about to show just came out in Clinical Infectious Diseases, I would say within, I think these were within the last 6 months to a year. And what these authors were looking to do between the 2 articles I'm about to show you next was, do we have another scoring system like the de novo score? Can we create another scoring system for strep species, just like we have the de novo score for the enterococcal species? So they looked at creating what's called, what now is called the Handock score. And so this first article was trying to create a scoring system for when you had a non-beta hemolytic streptococcal bacteremia. And just as a reminder for everybody, that is pretty much all the strep species, except for the beta hemolytics would be your strep pyogenes and your Agalactiae. So those 2 excluded, rest of the streps are in there. So they were trying to create a scoring system now known as the Handock score. So this was a retrospective study with 2 cohorts. The first cohort was patients with non-beta hemolytic streptococci bacteremia. And what they were trying to do in the first cohort was assess the general patient characteristics and outcomes to generate a scoring system. And then number 2, in the second cohort, they were trying to look at, okay, same thing, patients with non-beta hemolytic streptococci bacteremia, and they were trying to validate their scoring system that they created from the first cohort. And so this right here essentially is a depiction of the first cohort. So 26 patients with infective endocarditis, 197 with no infective endocarditis, and 116 that were unknown that were determined by an endocarditis panel. But they found a couple of things when they were trying to look at the clinical characteristics of who had infective endocarditis and who didn't when you were talking about these non-beta hemolytic streps. And a couple things that jumped out that they put in the scoring system. So the first one was there was a risk factor when the person came from the community. So community acquired right here was a risk factor for having infective endocarditis. Duration of symptoms, when the duration of symptoms was longer, was a risk factor for having endocarditis, just was like valvular disease, heart murmur, and those were all risk factors for potentially having infective endocarditis. Then they also looked at the pathogens. So they were looking at all those different streps. And the ones in red right up here in the top, there we go. The ones in red here at the top were given, they did have increased risk factors for having infective endocarditis, mitis, sanguinis, and bovis. I'll get into what's in those groups. But they also noticed pathogens that did not seem to give a risk for infective endocarditis, just like anginosis. So anginosis, strep anginosis, was actually not a risk factor for having endocarditis. And then also a part of the microbiological data, they saw that increased number of blood cultures, and monomicrobial bacteremia as opposed to polymicrobial bacteremia were also risk factors. So I promised I would show you the score and what was in those different groups. So in these, what I have on the right, these different groups, this is in the article if you ever do want to read it, so you can double check what strep you have when you get a blood culture back. But based off of those risk factors that I just pointed out on the last slide, they created the Handock score. And that is the chart on the left here. So starting off, everything gets 1 point. And if I can get this thing to work. Yeah. Here we go. So heart murmur or the presence of valvular disease or prosthesis got 1 point. I'll get to etiology in a second. Number of blood cultures, if it was 2 or more, got a point. Duration of symptoms, just like the de novo score for Enterococcus, got 1 point if it was greater or equal to 7. Only one species, so monomicrobial streptococcal bacteremia got a point, and community acquired got a point. Then when we look at the etiology, so the Handock score is pretty easy so far. This is the thing that you might have to look up, is basically if you have your patient there of which one, which of these strep species does emit. So like I said, there were certain species that actually gave a risk factor for having endocarditis and some that did not. So they gave a point if it was bovis, sanguinis, or mutans group. They actually subtracted a point if it was anginosis group, because when they were doing their study, anginosis actually did not have any, bacteremic patients did not have any infective endocarditis. And all other streps besides the ones that were listed got 0 points. So they neither affected, increased the score or didn't increase the score. And on the right, like I said, I kind of just spelled out the ones in red here are the ones that would all get a point, because these are all the pathogens or the species that are under bovis, sanguinis, and mutans. And these ones in green were the ones that actually subtracted a point because they did not show to have an increased risk for infective endocarditis. And so that was the anginosis group. So anginosis, constellatus, and intermedius. So how did this score do? When you looked at this score, so they did look at it, even though the cohort 1 was just to get the score or to produce the score, they did do sensitivities and specificities on it, which were actually quite good. Sensitivity of 100%, specificity of 73%. There was no significant difference between men and women when using the score. The cutoff they were using was between 2 and 3 points. And what I do want to point out here is actually that they did include the unknown category. And when they did that, the score or the sensitivity and specificity were pretty similar. But the negative predictive value, when you do have a good score that did not indicate high risk for endocarditis, the negative predictive value is very good at 100%. And the same thing when they did it in cohort 2. So they took the Handock score that they created in cohort 1. They applied it to the second cohort of different patients. And this was 37 patients with infective endocarditis, 264 without it. They used a cutoff of 3 or greater, and that's what's used in this Handock score now. Sensitivity, again, was very, very similar to cohort 1, 100% sensitivity, specificity of 76%. And I guess for hospital administration, they would like the right side of this slide, is out of all the cohorts, echocardiogram was performed on 42% of all patients in both of the cohorts. So if all of those patients had the Handock score applied to them and it was followed, actually that number would drop to only 31% of patients needing an echocardiogram. And so that would, obviously delay or, help delay discharges and help delay extra procedures or procedures that might lead to, that are false positive, that might lead to more invasive testing. Okay, and also they did a subpopulation analysis too, as well, when they looked at all of those patients who had some form of echocardiogram, and the sensitivities remained and specificities remained kind of equivalent to both the first and second cohort. So you might say, well, that's a great score. It does have good numbers, but the numbers were, kind of small in that first trial when they created the Handock score. So there was another study that came out after it. And basically what this study was looking for was to get higher numbers of patients and to try and validate again the Handock score. And then not only validate the Handock score when you're talking about strep bacteremia, but also compare it to, say, if you're taking the patient and you're just using the Duke's criteria. So how did it hold up against the Duke's criteria? So this was a retrospective study with 851 episodes of strep bacteremia. Endocarditis was diagnosed in 171 episodes, or about 20% of the entire population. And they used a score of greater than 2, so 3 or greater. So just like the first, like the first trial did. And so they basically separated their patients into, there was a bacteremic cohort, so any patient with a streptococcal bacteremia, and then there was this other cohort, was basically a collection of patients that the providers felt that there was, the patient was at high risk for infective endocarditis. And so they teased out the 144 patients that had, again, strep bacteremias, and they were put together for that 851 streptococcal bacteremia. Now, the only difference between kind of this trial and the last one that I just showed was that this study actually included all streps. So the last study excluded beta hemolytic strep, but this study actually looked at just all streps across the board to validate the score. So there was 851 patients that had any type of strep bacteremia. Granted, a majority of these, 71%, were non-beta hemolytic, kind of just like the previous study. Like I said, about 20% of them were diagnosed with infective endocarditis. And in general, across the whole cohort, 31% had a Handock score that was greater than 2, or basically 3 or greater. And so how did their trial go? Did it validate the Handock score just like the first one did? Well, again, among 607 patients with non-beta hemolytic streptococci, so this was the subgroup analysis, just like kind of the first trial, non-beta hemolytic strep bacteremia. 23% were diagnosed with endocarditis, and 35% of those patients, or 35% of all the patients, had a Handock score greater than 2. And the sensitivity and specificity remained good, 95 and 82% respectively, with a very good negative predictive value, 98%. Among all streptococcal species, again, the score still held up. So 91% sensitivity and specificity of 83%, again, still with a very good negative predictive value when you looked at, unlike the last trial, when you looked at all strep species. And when they looked at those 707 patients that were just purely in the bacteremic cohort, again, the negative predictive values held up again, 99 and 98 for non-beta hemolytic and all strep species regardless. And then unlike the last trial, they also tried to compare the Handock score to say, okay, I'm just using the Duke's criteria with these patients. And again, this Handock score did hold up as well. So you can see here, not so worried about the specificities, like I said, because when I'm using scores like this, I want a good sensitivity to rule out infective endocarditis. So we can see here that comparatively to, the 2015 Duke's criteria, the 2023 international criteria, or the European Duke's criteria, the sensitivities were actually improved. They were better. Specificity a little bit lower than those. And the negative predictive values were just on par with the various different Duke's criteria throughout the years. So again, this Handock score, when you're talking about streptococcal species bacteremia, did indeed hold up against, just against the imaging, as well as the other scoring systems that are out there. So to pull us back again against clinical scenario 4, technically, if I'm going based off of this hand-doc score, I would say that I at least have 3 or greater on this patient. So I have from the community, I have a duration of symptoms that are 7 days or more, and I have sanguinous, which is in one of the groups that got a point for being higher risk for infective endocarditis. So would I obtain an echocardiogram? I would say if you're using the hand-doc score, the answer is yes. And again, this is just like the de novo score, is not to replace your clinical judgment. It's just another tool in your arsenal to give yourself some leverage and not ordering an echocardiogram on everyone who just has a random strep, bacteremia, which we do see a lot in the hospital. So, okay. Clinical scenario 5. This is how you all look to me who are not infectious diseases providers. And that is yelling that we want an oral option. Just joking, but kind of not. So I think, when we talk about oral options for infective endocarditis, I think that the first thing that you have to go back is to the POET trial. And if you just read the abstract of the POET trial, which came out in 2019, it was a godsend. Okay, everybody with infective endocarditis can get oral antibiotics. Why is ID doing IVs and why are they still here? So I'd like to start by going through at least the POET trial at first, and then look at some literature that might be after the POET trial and some of my, hesitancies with the POET trial. So the POET trial was a Danish study, non-inferiority multi-center study, and they were only looking at a handful of different bacteria. So they were looking at strep species, they were looking at Enterococcus faecalis in particular, staph, and coagulative staph. And so basically they had an arm that was IV or they had an arm that was oral. But you had to receive at least 10 days of IV antibiotics before you went to that oral arm in the POET trial. And what they were looking for was all-cause mortality, unplanned cardiac events, embolic events, or relapse of the primary bacteremia. And they followed these patients up to 6 months afterwards. And so in a matter of speaking, which I won't go into this slide too much because this is going to factor into what the guidelines are representative, but again, only a certain number of bacteria were included in the POET trial, the ones that I listed above. They also had to have a couple of things happen if they were going to go to the oral arm. Basically, they had to defervesce with their fevers. They had to have their inflammatory markers go down. And also, which is going to play a factor, is all of those patients got a transesophageal echocardiogram as well to make sure that there was no complications that developed before they were going to go to that oral arm. They also, I will point out, is they also excluded people that had a BMI greater than 40 in the POET trial, but they did have native and prosthetic valves in this. And so again, this slide right here is basically, could you go to the oral arm in the POET trial? And again, this is basically everything that was listed in the inclusion-exclusion criteria. So essentially, did they receive 10 days of IV antibiotics? Did they defervesce? Did they have a transesophageal echocardiogram? Did they have a BMI less than 40? Or could they ingest the oral antibiotics and have no concerns for absorption? If yes to all of those, then you could go to the oral arm. The one thing I also want to point out with the POET trial was they were highly selective. They kicked out a lot of people who they deemed non-compliant. So IV drug users or people that they just didn't think were going to follow up with them in that oral arm. Because as we'll see, they were following up people, I think like 2 to 3 times, in the clinic when they were in the oral arm. I do want to point this out as well in the POET trial, that almost 50% of patients across the IV and oral arm had strep. And the reason I'm going to point that out is because the US guidelines say that we can treat strep infective endocarditis with 4 weeks of therapy. So I do want to point that out. Just remember that we can treat strep with 4 weeks, even if they have endocarditis, most of the time, if they have native valve, I should say. Because it was a Danish study, they do not have MRSA. So even though they were going to include it, even though they had staph, there was no MRSA that was in the trial. And they had a decent number of surgical intervention. So 38% of patients underwent some form of surgical intervention as well, which is a little bit higher than what we would see kind of in the United States. But with all of that said, essentially they found that oral antibiotic arm was just non-inferior to the intravenous arm. So on all the different fronts, all-cause mortality, unplanned cardiac events, embolic events, and relapse of blood culture. So they essentially found that there was no difference. It was non-inferior, the oral transition. So I will get into some limitations that I feel about this trial and kind of going forward. So I know that other ID providers might feel differently. I know that we all practice differently, and a lot of ID providers here in the United States, and especially in Europe, which have already adapted this, have no problems going to oral antibiotics. I will just mention some of the things that I'm a little bit hung up about, when you talk about this trial. One is that, this was highly selective. Like I said, 1% to 2% of drug users were actually, were included in it. They kicked a lot of people out because or excluded a lot of people because they didn't feel that they would be, compliant to this. Generalizability, there was no MRSA, there was only certain pathogens that were included. And again, in the oral arm, like I said, they were seeing these patients 2 to 3 times in the clinic during this oral arm therapy. And, sometimes that just is not feasible. We can sometimes never see patients after we, try to get them an appointment to see us in the outpatient setting. And there was certainly some possible bias because it was other physicians would refer, so there was some potential for referral bias. The reason I pointed out that 50% of the people had strep in the makeup of this trial was that while you could be randomized at 10 days after IV antibiotics, the median duration of IV antibiotics was actually 17 days. And so that's almost 3 weeks. And like I said, if you can treat strep with 4 weeks, you're almost really much there. You're almost just a week left on your treatments when you're talking about strep in particular. But nevertheless, this was an amazing trial to kick things off and to start things. The other thing I want to point out is that the oral arm was very hard. Again, don't memorize any of this. It's just to show you that they were using dual oral antibiotics, higher doses, and it was a lot of pills for these patients, and hence why the follow-up was so strict in the oral arm. So that was the POET trial to kick things off, and that was pretty much the largest trial that started to change the guidelines and change everything. Not so much for the U.S., but in Europe, it started to change guidelines. So I was trying to find, did the U.S. have any trials that kind of were looking at this IV versus oral? And if you happen to see this name, Brad Spellberg, so he gave a lecture in Grand Rounds last year for antimicrobial stewardship. So he actually was involved in this trial as well. But so this study was looking at the real-world application in Los Angeles for infective endocarditis. So this was a multi-center retrospective cohort. And their aim was basically to see IVs versus orals, and their primary outcome was clinical success at 90 days, defined as being alive without reoccurrence of bacteremia or treatment emergent complications. So is the oral comparable to the IV arm? And they did include a tad bit more species of bacteria than the POET trial did. So a couple more were added to this, and because they were trying to make this as, like I said, like the title would say, kind of real world application of oral therapy for this. And so they're kind of similar, like the POET trial, they had kind of this flow chart of could you take the patient to orals? And it was kind of similar to the POET trial. I mean, a lot of these are self-explanatory. Did the bacteremia clear? Can the patient absorb it? Would they be compliant to the oral therapy? And do you have an oral regimen that is susceptible? So they kind of, because they were trying to make it more real world, you see some of the other criteria that the POET trial had, like BMI and other things like that, were not seen here. Essentially, over here on the right, the exclusion would essentially be the kind of things that were here on, that talked about on the left. So any of those things that you could not say yes to, they were excluded. And their antibiotics were more reasonable. So their antibiotics, unlike the POET trial, which is using dual oral antibiotics when you transition that oral arm, these dosages and these antibiotics were a little bit more familiar to what we use just traditionally for other types of infections. I will point out that, when you were using beta-lactams, they were higher doses than normal, like amoxicillin you see here. So they were higher doses just because naturally with beta-lactam oral antibiotics, you have less bioavailability. So when they ultimately, after excluding everybody, they had 211 in the IV arm and 46 in the oral arm. While not statistically significant, there was a trend to higher prosthetic valves, pacemaker placement, and ICD in the intravenous arm, which would make sense. Those doctors that saw cardiac devices or prosthetic valves were just naturally using IV therapy more. In the oral arm, you would see that, here we go. In the oral arm, you would see that had more IV drug users, which is also probably self-explanatory because you had patients who might not be wanting to stay for IV therapy, or you couldn't get them to a facility, et cetera, et cetera. So that makes sense. And then so does, going along with this, so does this make sense. The IV arm had more aortic and mitral, whereas the oral arm had more tricuspid. And that would make sense if they had a higher number of drug users in the oral arm. Surgical management was only 28%. So that is, I would say, more in line with what we see in the United States. But I will say, unlike the POET trial, this study did have MSSA and MRSA combined together. So they did actually have MRSA in this trial. And what they found was that basically the oral arm was non-inferior to the IV arm. So, and lack of reoccurrence, mortality, and the absence of complications, they found non-inferiority to that oral arm. And when they did a multivariable analysis on the right, the things that they saw did contribute to the primary outcome would be age, MRSA, and dialysis dependence. So those were what they found were risk factors for having, a positive primary outcome. So this was their poster. Essentially, they said, the PO, just like the POET trial, the PO was non-inferior to the IV arm. It was statistically, non-significant between the two of them. And so their conclusion was that there was no significant difference when they were following up these patients in any of their primary outcomes. One outcome that was statistically significant was less adverse effects in the oral arm comparatively to the IV arm. And there's a number of other studies that I found in the United States in particular, is because we don't have a major trial like the POET trial. Most of the data behind oral therapy in the United States comes from, unfortunately, people who are IV drug users, because you're having to make that clinical decision if they're not staying, if they're going to be leaving AMA. So I did find a number of other trials that specifically dealt with those scenarios, which found that oral therapy was non-inferior as well, for what it's worth, in that specific clinical scenario. But I thought, to wrap up, I thought that this was a letter to the editor, I believe, in Clinical Infectious Diseases, but basically some doctor had plotted out, and again, nothing to memorize here, but some doctor, I think, plotted out all the different trials on the left, and then on the x-axis was basically all the different variables that can be seen in endocarditis. So my point to showing this is that this is amazing that we have POET trials. I think that these are, these ongoing trials are really extremely important. But I think that just trying to generally, I guess from my standpoint, generally trying to apply one of these trials to every patient and generalize this to every patient that you have where you think there's endocarditis, there's so many variables throughout all these different trials. It's just really, really difficult to try and generalize, one standard flow algorithm to all of these different cases, because endocarditis has all these different variables across the board. However, nonetheless, the European guidelines do in fact reflect the POET trial. And so what they're doing in Europe, our guidelines in the United States have not been updated, but what they are doing in Europe is they are essentially following the POET trial guidelines. So in Europe, this is coming from their guidelines for endocarditis. You can see here, this is exactly similar to the inclusion criteria for the POET trial. So in Europe, they're including those specific organisms right here. Did the patient defervesce? Yes. Did the fevers go down? Did the bacteremia clear? Is their BMI under 40? But the one thing I would want to point out, which might be difficult in the United States, is that was a transesophageal echocardiogram performed, and were there no complications? If there was no perivalvular complications or nothing seen, a worsening clinical disease, then they were allowed to proceed to treating the patient with oral therapies. That might be a little bit difficult here. But nevertheless, like I said, exact same inclusion criteria that was in the POET trial. And if yes, you can consider transitioning the patient to oral arms in Europe. And this is the kind of chart for their oral antibiotics that they're using in Europe, if anybody's curious, but it kind of really reflects what the POET trial was using. They're still using dual antibiotics. It is a decent pill burden, and you could see here rifampin is used and linezolid is used kind of in a lot of these different categories, which might present some drug-drug interactions or intolerances. But I think that is my time that I have with you guys. So I just want to say thank you for letting me present some of these decisions and dilemmas for you.
Thank you so much. That was a wonderful talk. Just a couple of housekeeping items. CME code will be shared shortly, and you have to claim the CME code on the EVMS CME website. There is a speaker feedback survey form in front of you. If you could please scan the QR code and complete the form, that would be wonderful. House is open for questions. Dr. Tahan, please.
Thank you. That was outstanding. Can you comment on getting blood cultures? I think a lot of confusion in my mind. Am I getting 2 sets to start, 3 sets? How often am I getting them when I'm screening somebody for endocarditis right off the onset?
So the question was about blood cultures, not only getting blood cultures when you're trying to examine for infective endocarditis or surveilling them after you might have diagnosed them. I think that, again, this might be personal preference. I think that, I think 2 sets of blood cultures, if I'm concerned for infective endocarditis, is reasonable when you're first starting out. Unless I have a clinical story where I'm worried about a pathogen that might not grow rapidly, initially on it, would I maybe be gaining? Sometimes in situations where I'm suspecting clinical endocarditis, but I think that it's subclinical or it's kind of this chronic subclinical infective endocarditis, I might be gathering actually more blood cultures before antibiotics because those might be a little bit less virulent pathogens. And so I want to gain as much data as I can to try and get before somebody puts the patient on antibiotics. And I think in terms of surveillance, well, I guess I've tried to back off of ordering so many blood cultures after I have the positive set because we were / maybe are having a blood culture bottle shortage. So I think I backed off to every 48 hours that I'm surveilling for clearance. Even with Staph aureus bacteremias, I'm probably not getting them daily. And if I were to get them, I'm trying to back off to maybe just 1 set of blood cultures if I'm just looking for clearance and not a diagnosis. So hopefully that answers that question.
Any other questions?
When you have the IV drug user in the hospital who pledges that they won't use the PICC line for IV drugs, you can stay for IV drugs. Most of the times we don't send those folks home with IV medication. Is that more like a medical legal issue, an issue of, you don't want responsibility for that quote unquote kind of patient in your practice, or are we trying to avoid harm to the patient? And I only ask because those same patients, we allow them to make decisions about their care while they're in the hospital.
Yeah.
But we don't trust them to make decisions outside the hospital. So they hold us hostage in the hospital. And I'm just trying to figure out what we're trying to avoid truly when we don't do that.
I think that's maybe some of my other colleagues who have way more experience, have a better answer for this, but I struggle with that, just like you guys do. I don't know what is better for the patient. Should I, send them home with this PICC line where if I know that they're an IV drug user, they actively could harm themselves. I mean, even if they're competent to make clinical decisions, doesn't mean that they're competent to stay strong and not to use and have easy access. But again, I think sometimes we might go overboard with that. I mean, we kind of label those patients when they have any history of having IV drug use. But, when you have somebody who might have been clean for 3 to 4 years, I'm a lot more flexible after talking to them and just evaluating them too. But then I think the second thing that goes to it, and this is also what I struggle with as well, is, well, I do have some evidence, like I said, to back me up with going to orals because this patient is not going to stay here. I have nothing else at hand. But do I give this patient linezolid where, say, I still need 3 to 4 weeks of treatment on? Do I give them linezolid when I know that there could be side effects, pancytopenias, et cetera, and so do I give them linezolid when I know that they probably won't come to me in the clinic or get labs drawn? So I also struggle with that side of things. Not that I wouldn't want to give them something oral to treat because I do have some data behind it, but I guess would I harm them more if I'm not monitoring something like linezolid or one of those meds like that? There was some data behind dalbavancin too. When I was at ID Week, was it a year or 2 ago, they were considering doing dalbavancin for some of those IV drug users because that dalbavancin shot would last you 2 weeks, especially when you're talking about Staph aureus. I think there needs to be more study behind it. I think it's a reasonable thing, because if you give that person dalbavancin shot inpatient, you get them by 2 weeks, and all they have to do is maybe show up for one more shot, and that is at least 4 weeks right there. The only thing against that I saw, which was early literature, was that because dalbavancin lasts in your system so long, was that would it go under the threshold of treatment for a high burden disease? So it'd be fine for, say, something like cellulitis, which you can cure in under 2 weeks. But does the level of dalbavancin drop when you're trying to treat something long term? Does it drop the levels in your blood under what your threshold would be? So I think there's still some studies that need to be done in that realm too.
Thank you. And I echo Dr. DeHaan's comment. That was outstanding.
Thanks.
Thank you. With this, we wrap up the grand rounds for today. Thank you so much for the excellent talk, and thank you everyone for joining us today. We'll see you.